Dr. Welsh, please take it away.
Thank you very much. Good evening to everyone. Thank you for joining us. Dr. Susan Bailey, a distinguished allergist, immunologist from Fort Worth, Texas, is the 175th president of our American Medical Association. She is a fierce advocate of physician autonomy in private practice, and she's held numerous leadership positions at the AMA, including serving as speaker and vice speaker of the AMA's House of Delegates, where she's facilitated those wonderful videos we've all come to love. She's also been chair of both the advisory panel on women in medicine and the AMA Council on Medical Education. In addition, she represented the AMA on the Accreditation Council for Continuing Medical Education, the American Board of Medical Specialties, and COLA. Her dedicated service in organized medicine extends also to local and state levels, where she has served as board chair and president of the Tarrant County Medical Society, and as vice speaker, speaker, and president of the Texas Medical Association. We thank Texas and the TMA for loaning Dr. Bailey to us, and I would be remiss, Dr. Bailey, if I didn't say God bless Texas. Dr. Bailey's been an allergist in private practice for over 30 years. She completed a residency in general pediatrics and fellowship in allergy immunology at Mayo. She's been awarded the title Distinguished Fellow of the American College of Allergy, Asthma, and Immunology. A strong leader, a helpful colleague, and a supportive friend, it is my great pleasure to welcome our AMA president, Dr. Susan Bailey. Thank you for joining us this evening.
Oh, thank you, David, for such a lovely introduction. It's wonderful to be here, and it's my honor to welcome everyone to this evening's program on the unique challenges facing women physicians during COVID-19, as if we didn't have enough unique challenges. The pandemic has changed all of our lives in such profound ways, personally and professionally. And the stress and the anxiety that results from these changes brings unique challenges and adds urgency to this conversation. This webinar is an opportunity to explore some of those issues and get them out into the open. Nobody needs suffer in silence in this pandemic. We may be physically distant from each other, but we're still very much connected by our emotions and our shared experiences during this unusual and very difficult time. I'm excited about tonight's program because not only will you hear about the challenges many of our colleagues are facing in this pandemic, you'll hear about solutions. Now, as physicians, we're field generals who organize and navigate our patients' care. But lots of us are field generals on the home front as well, navigating our family's health and well-being. We're daughters, we're spouses, we're partners, where some of us are moms and grandmoms like me. Now, sometimes these important responsibilities compete and collide. The AMA's own research shows that even when women physicians are the family's primary breadwinner, they also are responsible for the lion's share of the work at home. Now, this isn't a surprise for any of us, especially for the moms out there. But I think it's really important in the context of this conversation because, as we all know, women are often asked to do more. That's true even when we have professional careers, whether it's in medicine or in any other field. Before I introduce our speakers tonight, I'm just going to share a very brief story with you. When I was a mom with 2 children early in my career, and I bet some of you will have the same experience. So I was just starting in practice. I had just finished my maternity leave with my second child, and my first day in my new practice was going to be on the 5th of July. Had family over for the 4th of July. We had moved back to Texas. Everybody was very excited. And during that weekend, my brother-in-law brought my niece over to me saying, "Oh, what are these things on her stomach?" And I said, "Oh, those must be fire ant bites." You know, they were new to Texas and they didn't know about fire ants. And, fire ant bites, for those of you who aren't familiar, start with a little sterile pustule on a pink background, and it's a very characteristic type of lesion. And so, of course, 2 weeks later, my first son caught chicken pox from his cousin. And 2 weeks later, the baby got it, and he was only 7 months old. Now, none of them got super sick, fortunately, but, and this was in the varicella vaccine days. I'm dating myself, but the baby was really fussy and whiny. And so not only did I need my housekeeper and my mother, I needed a sitter and just all sorts of help to keep going in my practice. Because good Lord, I just started into practice. I didn't want to take off to take care of a sick child. So one day during this period, I come into the office, I'm fried. I'm just completely, I've had it. I'd been up late with the baby and he'd been driving me crazy. And so when I got into work that day and kind of slammed the back door, one of my future partners said, "Oh gosh, I'm so sorry. If you need to go home, please, let me know." And I said, "Oh my God, please don't let me go home." This is the only quiet and decent organization I've had all day long. And he gave me the funniest look, and I don't think he had any idea what I was saying. But I think a lot of women can relate to that story. We have so much we're responsible for, and all of that is magnified in a crisis. So I am so looking forward to hearing from our speakers, and we're so delighted you're here. And let me introduce our panelists. First, Dr. Kimberly Templeton is Professor and Vice Chair of Diversity in the Department of Orthopedic Surgery at the University of Kansas. Dr. Templeton is also past chair of the AMA's Orthopedic section, past chair of the AMA's Women Physicians section, and past president of the American Medical Women's Association. Dr. Teresa Rohr-Kirchgraber is Professor of Clinical Internal Medicine and Pediatrics at Indiana University. She's also past president of AMWA and is currently executive director of the IU National Center of Excellence in Women's Health. And Dr. Marie Brown is a director of practice redesign of the AMA's Professional Satisfaction Practice Sustainability Group. She is also a professor of internal medicine at Rush University in Chicago. We are so honored to have all three of these amazing physician leaders with us today. So let's get started. Dr. Templeton, I'll turn it over to you.
Thank you so much, Dr. Bailey. I greatly appreciate this opportunity. As you mentioned, and as we've discussed in other venues, the pandemic is shining light on issues that we knew existed and were trying to address prior to the pandemic, and that includes physician well-being. As we know, there are a variety of issues that also during the pandemic are impacting well-being, such as increased workload, availability of PPE, risk or at least concerns about acquiring or transmitting the disease, changes in ways of working, treating a condition with no cure or no vaccine at this point, job or financial security, and importantly, isolation or feeling of loss of social support. So how is this impacting mental health? Well, we're starting to see some data emerge on this issue. There's been data out of China looking at mental health issues faced by healthcare professionals that shows an increased prevalence of depression and anxiety, especially among women. There's about a 30% prevalence of depression and anxiety among women and about 20% among men. Although those studies don't differentiate by type of profession, and many of the women in those studies are nurses. There's also data now coming out of New York City that shows an impact of the pandemic on mental health. About 40% of physicians have had issues with depression, and about 15% have had issues with anxiety. But those studies don't differentiate based on the gender of the physician. But are there issues in particular that could be impacting women physicians? And my slides are not, could you advance my slides, please, if possible?
I can go ahead and share my screen. One second.
That would be great if you could go to next slide. So could women be facing additional challenges or different challenges? The increased workload at work can be more challenging, especially when there are other duties and even increased responsibilities at home. As Dr. Bailey mentioned, pre-pandemic, women physicians were estimated to perform about 70% of the work at home and had the primary responsibility for child care and family care. this doesn't go away just because there is a pandemic, but how do women physicians balance medical practice with family care if daycare, elder care, and schools are no longer options to help care for family members? Women physicians may also feel guilty if they are in a situation where they are not able to socially isolate or socially distance, if there are not other options for caring for family members, yet they still need to continue to be present in the hospital and are not able to provide care remotely. And so this can cause additional stressors on women. There also is the issue with loneliness. We know that medicine has been called the loneliness profession. And for some women, this is especially true, frequently because they are a minority within their workplace or because of the responsibilities at work and at home. They don't have a lot of time to develop social networks. So what is physical distancing then going to do in terms of loneliness for physicians that already are prone to this or in a position where they could be lonely? And this is in addition to the impact that the pandemic has had on research, leadership, and other duties that are necessary for career progression. And this is in addition to the factors that already are facing women even before the pandemic. In this study that we worked on, it was published last year from the National Academy of Medicine. We looked at different risk factors for burnout among women physicians. We think burnout may be higher among women physicians, but the risk factors are certainly different for women than they are for men. Things such as lower rates of promotion, recognition, difficulty in finding mentors, lower pay, increased caregiver responsibilities, which again, I just mentioned is especially true during the pandemic, issues with imposter syndrome, and then continuing issues with sexual harassment, bias, and discrimination. So women are already having issues with things that could make them burned out, could potentially be impacting their mental health, and now all of the changes of the pandemic are on top of that. But when we look at women physician wellness, it's not as though burnout and depression are one and the same, but for some, they certainly are linked. And so women, again, have higher risks of burnout, have higher risks of depression, but those aren't necessarily, again, in the same individuals. But what is the impact of the pandemic? And that's something about which we need to know more. But women physicians have been referred to as the collateral damage of the pandemic. What are some of the issues that impact the mental health of physicians, especially women physicians? This is a survey that came out in 2,000 female physicians that came out in 2016. About half of these women thought that at some time during their career, they had met criteria for a mental health condition, but had not sought treatment. And that's concerning. And when asking why they didn't seek treatment, over 2/3 said it was because of a stigma-related issue, including the issues raised by questions they would have to answer for their state medical board. So why don't physicians seek help? The study that I mentioned previously is data that we know from in other studies also, and we know that the issues are the culture of medicine. We go into medicine to help others. We're not in medicine to seek help ourselves, and sometimes we don't think we need help, or if there's an issue, we think we can take care of it ourselves, but unfortunately usually don't do a good job of that. There is the stigma, again, of seeking help, and importantly, the impact on licensure. But what is the ultimate impact then if a physician does have a mental health issue? And unfortunately, the data is frightening. If you look at the rate of suicide among male physicians, it's 1.4 times the rate of males who are not physicians. But even more staggering for women, the rate of suicide among female physicians is over twice that of women who are not physicians. And when you look at physicians who die by suicide, physicians who die by suicide are significantly less likely to have sought help for mental health conditions before they perished than are other people, non-physicians, who also die by suicide, even among populations with similar prevalences of mental health issues. So what can we do to address this? Well, there is, again, the culture of medicine, the stigma. These are obviously things we need to work on, but more tangible things that we can address are the questions asked by state licensing boards on licensure and renewal applications. In this study, all applications across all 50 states and Washington, D.C. were assessed. The researchers looked at whether or not these forms still continue to ask questions about current or past diagnoses. if there was a history of a mental health condition, or if there was past impairment due to a mental health condition. If you looked at physicians who had licenses in states that did or did not ask those type of probing questions, those in states that still asked specifically about diagnoses rather than impairment were 20% more likely to be reluctant to seek help. This is the report of the Federation of State Medical Boards work group on physician wellness and burnout. And they provided, as we know, recommendations in terms of what state medical boards should be asking. They recommended that the state medical boards should evaluate whether it's actually necessary to ask these probing questions, especially about physician mental health, addiction, or substance use. And to carefully review our applications to determine if we have made an appropriate differentiation between impairment and illness or diagnoses. And also ask that state medical boards emphasize the importance of physician health, self-care, and treatment. I've been a member of our state medical board for over a decade, and our mission is to protect the public, but a great deal of that duty to protect the public is our responsibility to support physician wellness. So because of concerns with physicians seeking needed physical or mental health resources pre-pandemic, I started an initiative with our state medical board about 18 months ago to change the language within our state licensure applications and renewals to encourage physicians to seek the help that they needed, while also maintaining patient safety and public safety by having our applications focus solely on current impairment, not past or present diagnoses. And I would say at this point, this is even, looking at these applications is even more critical now, because I don't see a reason that physicians who are under additional stress from the pandemic, especially if this, as in women, is exacerbated by their roles outside of work, should avoid seeking care because they're afraid of the impact of this help seeking on their medical licensure status. And so the previous questions that we had in our applications in Kansas did the usual, unfortunately in some states, the look back questions. Within the past 2 years, have you used alcohol or other drugs to which you may become dependent? Within the past 2 years, have you had a physical, emotional, or mental illness or disease or drug addiction? Within the past 2 years, have you used controlled substances other than under the supervision of a licensed provider? Have you practiced while suffering from a mental or physical disability? Or do you currently have any physical or mental health problems? And so in working with the attorneys on our board and other members of our state medical board, we changed our licensure application and renewal, not only for physicians, but for every profession that we license. So now those questions are honed down to a single question, which focuses on current issues, and impairment rather than diagnoses. So the question is, do you currently have a mental or physical health condition that impairs your judgment to, or would otherwise adversely affect your ability to practice medicine? And this is the only thing that we ask. My goal when I started this work with our state medical board was to hopefully take this, once we worked on this successfully in Kansas, to take this beyond Kansas and to try to work with other states to see if we could do something similar. And this is a project that we've now started through the American Medical Women's Association. The goal of our project is to project the message that everyone, including physicians, is vulnerable to physical or mental health conditions, and to encourage physicians to seek the help that they need. So currently we're assessing the language in state licensure applications and renewals. There are a group of us that are looking at these applications, and we're looking for language that focuses on impairment rather than diagnoses. And if they are asking about diagnoses, that mental health questions are posed in the same way as physical health questions. We've not finished our evaluation, but about 17 states so far have language that is more in line, with what the Federation of State Medical Boards had recommended. So hopefully we'll have the results of this soon. And as you know, our AMA adopted policy in 2018 to improve physician wellness and eliminate any barriers that stand in the way of physicians accessing needed care, and ask the state medical boards focus on impairment and impairment that impacts the ability to practice medicine. So I think, and I hope that our initiative through AMWA is reflected in the policy, or reflects the policy of the AMA, and certainly the policy of the AMA was critical in our developing this program. Our goal eventually is to cite the language of the state medical board applications on our website, so that if other states want to change their language, they can see what other states have done and maybe find some model language. Also, if a physician doesn't know what language is on their licensure application, then they would have a resource to go to be able to see that. At this point, we're also engaging with other interested stakeholders, and we're identifying champions in each state to try to push this forward. We're also in the process of developing a roadmap for the state champions to include such information as whom should you contact in your state to try to get this process started. What should you say and what should you avoid? Always the question is, do we talk about the ADA or not? What are next steps in each state? Do you have to talk with the board, and how do you maximize success? We're also currently working on developing a series of FAQs. So hopefully this work will continue, and hopefully this will make an impact. But I think if we can reach out to individual states that have not changed their language to be more consistent to that recommended by the FSMB, I think this is going to have a dramatic impact on physician mental health. Hopefully people will be more willing to seek the help that they need. And I would like to thank the AMA, our AMA again, for the invitation to speak. And I would also say in closing, just a reminder that tomorrow is the 3rd annual National Physician Suicide Awareness Day. I think this is a time for us to acknowledge those we've lost, to remember to care for ourselves and each other. And there's no better time than this to commit to affecting needed change.
So you brought up a lot of the issues and a lot of the problems. I wanted to kind of tell you a little bit of some of the potential, how should I say, successes that have actually come about with COVID. We put together an article that is currently under consideration for presentation for publication, and it's called Reframing Academic Productivity, Promotion, and Tenure as a Result of COVID-19. This was put together with a number of faculty from the IU School of Medicine because we recognize that COVID-19, the pandemic, has changed the way that we do things. But perhaps then it can change it in a not so bad way. One, we put forth some recommendations. Consider having a faculty developer. So the faculty developer is somebody who is your mentor, is your sponsor. It could be a variety of different people, but the idea is we can't just keep doing things the way that we've been doing. We have to look across departmental lines, division lines, even within different schools to develop perhaps new projects. We also recognize that there is a lot of monies that are coming out now for research projects that have to do with COVID. Is there a way that your current project could be tweaked in a manner such that you might be eligible for some of those funds? A number of faculty have become very involved with social media. Maybe we need to count that a bit more. And how can we recognize that and have that counted? Is the fact that you make a statement on social media and you have a following of 10,000 people, shouldn't that be important, and shouldn't that be documented and counted in some way for your promotion and tenure? What about the fact that you were involved in some civic-minded or community-minded programs? And the fact that you were the main medicine person for the school system or for your church program or whatever, we have to give some credibility and some credence to those things that you're doing, even though in the past they were not really considered when it came to promotion and tenure. We also recognize that perhaps you need to explain a bit about what you've been doing. We know that the pandemic kind of changed your research projects. You can't go into the office. You can't bring your kids into the office. You're trying to do things at home. We know that the number of grant proposals, the number of papers submitted has significantly decreased from women during this pandemic. So maybe we can find another way, perhaps describe a little bit in your personal statement about what you were doing during this pandemic and how it impacted you, and highlight some of those other things that you were doing that was helpful not only to the community at large, but also to your academic community. Perhaps you spent less time in your research project and more time covering for those clinical sessions that other people couldn't do. Those are the kinds of things that we want to be able to promote. And let me kind of show you a couple of examples. So we were having a discussion with the women in medicine and in a virtual chat. And at first I thought, well, this is kind of seems like a stupid thing. I don't know, a virtual Zoom, whatever. But as we started talking, we started realizing that the group that was there were not mostly the ICU folks. I mean, we were just kind of like what we thought of ourselves as kind of the typical docs, and we felt a little guilty about it. So from that discussion, we actually put together an article that got published on Kevin MD. Okay, it wasn't the New England Journal, but you know, it got read by over 10,000 people. And it got parlayed then into another a podcast on NPR about the guilt that we felt about not being on the front lines. And we raised the question, is this just women? You know, are women this more than men? And in actuality, maybe a little bit so, but we heard back from so many physicians out there who were feeling the same way that we were. And just having that discussion, well, it helped a little bit. I felt guilty when my neighbors came and they chalked on my driveway, you know, 2 superheroes live here. And I said, but I do outpatient medicine. I don't know if I'm really a superhero. And I was feeling bad about that. But having this opportunity of sharing was fabulous. And, you know, we got a publication out of it. We got a podcast out of it. And I think we did a fair amount of good by being open and being able to share with other women and other women physicians. That then led to another article. I have medical students that work on the sex and gender elective, and it can be virtual. So I went from having 1 student a month to having 10 in 1 month and trying to find what they can do and how they can do it. And one of my medical students helped put together this article that got published in Health Management, an international journal, about superheroes behind the scenes of COVID-19. Recognizing that being on the front lines is great and we appreciate all of that, but there were a lot of people doing things behind the scenes. There was a woman who was the chair of cardiology who helped to turn a lobby into a hospital ward, and she actually was pushing around the beds. And we had others who learned how to do virtual stuff in an instant and learned how to actually supervise residents all virtually. There are so many different ways that our physicians were superheroes, even if they weren't on the front lines. This then got my student a publication that she can put on her CV. And we always look when we write anything is to try, who can we help to share this with us? We know that COVID-19 pandemic has had an impact on many folks, particularly in the scientific community. Our numbers of papers has gone down, our grants have come down, we're not spending our grant money the way that we had envisioned doing. We have to kind of redesign all of those things. So whatever possible way that we can do more things together, whatever possible way that we could find opportunities to share some of the successes, then we need to. So our plan is eventually to kind of level the playing field. And these are my, I guess you could say, let's find words of wisdom or some silver linings that have come out of this pandemic. Develop faculty developers within an institution, those people that are going to help you look beyond your individual walls, look beyond your departments to reach apart departmental lines to put together projects together. Organize and document what we're doing on social media, and then make it part of the promotion and tenure committee or the process. And rethink our studies so that we can find ways of perhaps including information about pandemics. For example, the pre-med division of AMWA had brought up a question about whether or not the pandemic had changed the thinking processes for pre-meds. Were they more enthusiastic or less enthusiastic? Well, the IRB just went in today, and we've already started the process on evaluating the pre-meds, and with the major question of, did the pandemic encourage you to consider keeping going forward with medicine, or did it make you rethink your thought process? And I think it'll be kind of an interesting study. We want to, consider including a statement in the promotions package that talks about how the pandemic affected your work, not as a whiny, but as a, you know, there were some impacts and this is how I overcame them and this is how I work with them. We also want to receive credit for the civic work and the civic engagement that you did, the talks that you gave on the radio, the television shows that you did, whatever. All of those things had an impact on your community, and by that, it impacted your institutions as well. Perhaps we ought to waive the requirement for peer review teaching. Most promotion and tenures committees, you have to have somebody watch you and teach and to document what you're doing and how you're doing it. You know, with the virtual learning and with the changes that have occurred, maybe that should just be taken out of the process for the next couple of years or so. And maybe a little less weight on teaching evaluations. Many of us have had to go from bedside teaching to virtual teaching and redesigning our courses. One, we should get credit for redesigning the course, but two, you know, perhaps our teaching evaluations, as important as they are, we give them a little less weight because we've all had to change how we do things and so quickly. The last is recognize the bias for our colleagues who are people of color. Whether or not the pandemic affected us individually with illness, it affected our communities. And just knowing that members of your community have been suffering, it's impactful. Trying to be supportive and understanding and recognizing that health disparities have an impact on the community, whether or not that illness is a direct effect on you. I know, just being from a Hispanic background, and every time I looked at those numbers, there's a little piece of me that just died because I wanted to be there. I wanted to help. I wanted to be part of it. And even though only a couple members of my family have gotten ill with this, nobody's had any long-term lasting effects. Still, members of my community have gotten ill in many ways. I heard today about a family who they lost their jobs and they really didn't have a lot of food, and kids were getting skinnier. And their pediatrician asked, "What's going on?" And finally was able to get it out of the family that it wasn't an illness. They just didn't have money to get food. There's so many different ways that this pandemic has affected us. I appreciate your time today. I yield my time.
Great. Again, thank you. And if you think Dr. Templeton's hard to follow, you're pretty hard to follow too, along with Dr. Bailey. So thank you for all of you out there who took the time this evening. It is a privilege to speak with you tonight. As you heard, I split my time between seeing patients as well as being the Director of Practice Redesign. I'm going to share and focus a little bit more on solutions, some COVID related and some that are more generalized. But I think I always feel grounded to think about what a wonderful profession we are involved in. And I like this quote from Don Berwick: "What we do every day touches the highest aspirations of a civilization. For many of us, this was a calling. And this should give us, and usually does, give us great spiritual satisfaction. Joy, not burnout, ought to rule the day." Next slide. But if we look at what's happening now, it really has unveiled a problem that has been present for a long time. The work-life imbalance hits gender, as we talked about, as Dr. Templeton and Dr. Kirsch-Graber shared eloquently. But if you look at the third line there, women physicians do not have trouble balancing competing demands any more than men. It is simply a more common expectation. And I'll show you the next slide. A recent study just published this month by my colleague, Vice President at the AMA, Christine Sinsky. And the conclusion here is that looking at disparities by gender and practice setting, the upshot is that female physicians may have a higher burnout level, but it may be because they are in or funneled into lower resourced settings. And that's where I'm going to focus a little bit of my, my time here. Next slide. So just to level set, we all know what burnout is, but just for the few of us who may need a little reminder, depersonalization, emotional exhaustion, and feeling of loss of personal achievement. And sometimes it's your colleagues saying, referring to a patient with that depersonalization, the train wreck, or coming to work said, I just can't take it anymore. You know who those people are because you're seeing them and you want to run the other way because they're downers. And now with what the stress, the added stress, if you hear somebody saying, I could have, I should have, I wish I had, those are calls for calls of distress. And we want to hear our colleagues loudly. And we have some opportunity to provide some peer-to-peer support. But when you see somebody struggling and not enjoying medicine, that should be a time to say, I wonder if that person needs a little bit more help. And then turn to many of the resources out there, some at the AMA, that can help you with peer-to-peer support. Next slide. So the causes of burnout are myriad, and they're just worsened, next slide, by the pandemic. And a solution is to exit practice, but that is a solution for only that one person, and it adds more work to your colleagues. Divorce, substance abuse, and sadly, suicide. And many of you are familiar with Dr. Breen's story that was highlighted in the New York Times, an ER physician who contracted COVID at work probably, and then took her own life. But what are the effects on our teams and our patients and the organizations? You can bring these arrows in, next slides. All the things on the left go down and all the things on the right go up. And that does not serve our patient well, and it's contagious. Next slide. Burnout is contagious. But the cost to the organization is huge. So when we have to make that return on investment to pay attention to this, it costs 2 to 3 times the physician's salary to replace that person. And in fact, if most of your physicians are only working at 75% effort, and you have 600 physicians, you've in essence lost 150 physicians, but you're paying all those benefits. And if you asked each of those each of those physicians, what is it that you need so that you will bring that, you'll go back to full-time effort, you'll open up that clinic. Every physician knows what they need to do that, and it has to come from them. Next slide. So the causes of burnout are huge. We don't have time to go into all of those, but the layer on top of this, what Dr. Templeton shared with the stresses of COVID. Next slide. And it's good also to remember what brings joy to us as a physician. So feeling proud of the work we did. We don't mind working 10 or 12 hours when we know that we saved somebody's life. But if most of the work or 50% of the work we did did not require an MD or a DO, that's demoralizing. We're frustrated when the mission is not aligned, when we have one foot in each canoe. Am I supposed to prevent people from getting ill? Or am I being pressured to put heads in beds? When there's a malaligned mission, it's demoralizing. And autonomy. As more of us become employed, the control over the day has lessened. And this is so important when you have another job at home, either taking care of your family, your parents, or other concerns at home. Next slide. So how can we thrive, not just survive? And I'm going to highlight just a few of the toolkits that are totally open access, free, to save hours each day so that you can deliver better care, spend more time with your patients, and finish the work when you get at 5 o'clock or 6 o'clock when the day is done. Lights out, that should be charts closed. We know that most physicians are spending 2 hours at home. We can't take doing documentation. We can't take our patients home. We have a choice. We can look at the patient and document at home because we can't take the patient home, and that's what's happening. Pajama time, 2 or 3 hours of work at home. We know from a study published in Annals by Dr. Sinsky, for every 1 hour of total face-to-face time requires 2 hours of documentation time, and that is just not sustainable. And it's leading to burnout, the primary cause of burnout. Next slide. So these are there's a screenshot of the landing page for stepsforward.org. Again, open access, don't even need to give us an email. These don't need to be a physician, do not need to be an AMA member. Totally open access. And because of that generous spirit, many of the authors and contributors, hopefully they're on the call today, who will contribute some of your success stories, have been equally as generous. Sharing protocols, sharing emails, sharing agenda items, sharing curriculum, so that we can all lift all the boats. Next slide. We think that our opinion is that personal resilience as a cause of burn is only really about 20%. The culture is about 40%, and the inefficiency of the practice and the under-resourced practice in which we work is 40%. I'll next slide just show one slide on culture, and there's lots of toolkits there. If you're on this journey, you may be at the beginning in the lower left as a novice, and you're talking about mindfulness and resources for exercise. Maybe you're at the competence stage and you recognize the return on investment, or maybe you're an expert. Go ahead and slide the next 3 in. At the expert stage, and leaders are doing this around the country, their compensation is based partially on the burnout survey, the mini-Z, whatever you're using, the health of the workforce. And that is really an enlightened organization. Next slide. So this is just a list of some of the toolkits that are there. Telemedicine, very popular now, and we're writing one on telemedicine and team-based care. Next slide. With the pre-visit lab module, I know I did this myself and saved an hour at least a day. Next slide. By simply changing to annual prescription renewal for chronic meds, I'm also a geriatrician, easily able to save 2 or 3 hours a day. And this toolkit shows you how to do that. Next slide. Next slide. Or make those go in. So night calls go down, errors go down, patient satisfaction goes way up, which I didn't think it would. And you continue to see the patients as often as you need to, but you have more time during that visit to counsel the patient, to coach the patient, and increase medication adherence. Next slide. In Boston, Dr. Strongwater at the last ACPH, the American Conference on Physician Health, shared what they did behind the scenes. And by simply using wide screens, decreasing copied chart messages and labs that go into your inbox that are not ordered by you, can save hours a day. I know when I turned off my notifications, my inbox messages went down by half. Very few of my colleagues know how to do that, and that is set by your internal, your own organization IT department. They can turn it on when you begin to work, or they can turn it off. At my institution, they turned it on for primary care and turned it off for all the subspecialists. They're rethinking that now. Next slide. Melinda Ashton from Hawaii wrote this piece in New England Journal and was generous enough to author a Steps Forward module on getting rid of stupid stuff, gross module. She walks through how she did it so that you can do it in your organization as well and save thousands of hours across your organization. The AMA also has a website showing how to debunk debunked regulatory myths. So often, the regulation from CMS or Joint Commission is overinterpreted by our in-house compliance officer out of fear of getting in trouble. If the doctor does it, then we will be less likely to get into trouble. And this is not sustainable. And we need to know where that regulation, what is the regulation, and not overinterpret it in our organizations. Next slide. This is Dr. Sinsky on the right, and I love her quote, "We wouldn't think of asking lawyers to be the court stenographer as well while they're trying a case. So why does anybody expect us to document what we're doing when what we do, I think, is a bit more important at the time?" So in-room documentation, team documentation is absolutely what we need to be lobbying for and we have tools to help you do that. Next slide. With team documentation, this is a picture from Kevin Hopkins, who leads the ambulatory effort at Cleveland Clinic. He started a new model with 2 MAs to every 1 MD with in-room support. They Everything was done at lights out. Everybody left. Nobody had work at home. Revenue went up, and joy was returned to the practice. He is a senior physician advisor now that I work with closely, and one of your coaches if you choose to work more closely and to avail yourself of some of the tools we have. Next slide. Just let that slide over in the interest of time. Click on that. We need to share the work. It can't all fall on our shoulders. Next slide. And back to COVID, and we're going to hear from Dr. Lubin Johnson on the bottom right. AMA has done some wonderful work on COVID and the epidemic. I encourage you to look at this. It's recorded. Next slide. We have a new tool, Steps Forward, just for the this crisis with Tate Chenefelt, John Ripp from Mount Sinai, myself, and Dr. Sinsky. I encourage you to look at that. Next slide. These are some success stories that are on the website so that you might find some of them applicable to your location and learn from them. Next slide. We have a burnout survey pre-COVID and a COVID survey now that is anonymous and free. I encourage you to look into that for your organization as well, with coaching then to decide what you could do once you have the results and where you can make your intervention. Next slide. Next slide. So some of the solutions from the field we've heard about at Stanford. I just had a conversation with Dr. Tate Chenefelt. They have more resources than many of us, but they were able to reimburse for 55 days what was needed in the home, whether it was a nanny, an elder care. They reimbursed for physicians and all of the employees at the hospital. Now focusing now on tutoring programs and promotions. To your point, Dr. Hirsch-Graber, they relaxed the milestones for promotion already, and they're thinking of making it opt-out rather than opt-in, so that you don't have to look like you're weak to extend it by 1 year. So that's already in place and could be done at your institution. Next slide. We'll finish up here. So you can measure, AMA can help you measure the stress that your organization is experiencing now and your colleagues. Next slide. And it's at no cost. Next slide. These are the organizations. Next slide. And I encourage you to look at the resource center the AMA has to learn more about these. And my last slide just has the websites. And I'll turn it back to either Dr. Welsh or Rick Abrams. And thank you for your attention.
I was feverishly taking notes. I hope everybody else was. There's some really good stuff that was just presented, and I think it's applicable to everyone on the call and maybe those that didn't make the call. Rick, do we have any questions in the queue?
Well, Dr. Welsh, first, I appreciate that. Before we get to our questions, I'd like to recognize our co-sponsoring organizations, okay, for, if you will, a reaction. Maybe they have some questions on their own. So first, I'd like to recognize Dr. Lubin Johnson, who is our current chair of our Women Physician section at the AMA. Dr. Lubin Johnson, it's all yours.
Thank you, Rick, and thank you to our panel participants, our panelists this evening. You have highlighted some significant issues that have occurred during this pandemic. But more than that, offered some great solutions on a lot of levels, both professionally and personally for women physicians. And I want to thank OMSS for inviting us to be a co-participant with you this evening for this webinar. Thank you so much for thinking of us and bringing us in. And we are overjoyed that we had the opportunity to participate this evening.
Thank you, Dr. Lubin Johnson. Now I want to recognize Dr. Nicole Sundu, who is the current president of the American Medical Women's Association. Dr. Sundu.
Thank you so much, Rick, and thank you to everyone. I really appreciate the opportunity to be here this evening on behalf of AMWA, the American Medical Women's Association. It's really an honor to co-sponsor this discussion with all of you. I don't think I could say anything more profoundly or eloquently than our amazing panelists have already done. As Dr. Lubin Johnson said, they've offered not only some wonderful perspectives, but some really impactful solutions. And I really want to celebrate that. I do have one question, if we have some time. I don't want to take up time from the audience, but I'm curious because we're all so aware of the incredible disparities that our communities of color have faced during the pandemic. And I'm curious to know what our panelists' thoughts are about, they've spoken so beautifully about the unique challenges facing women physicians during this time, but I'm curious about their thoughts about the particular issues that women physicians of color are navigating and potential solutions and opportunities.
Well, I think just one, the awareness is helpful. And also I think the awareness that it's not just necessarily that particular person, but their community. And being able to reach out and have other resources available. I know just in the office, it's been helpful to have a social worker who you can, be able to contact. I also have been utilizing our pharmacists, our clinical pharmacists, to find new ways of getting medications cheaper for patients so that they don't have to spend as much of their discretionary income on medications. But also just to recognize those folks that are working with me that have had some trials. One of our MAs lost her father during this. She's now taking care of her 4 younger siblings pretty much on her own. I mean, that's a lot. And so I think, for me personally, just being open, being aware, but also sponsoring discussions like Anne was going to be doing. I think this Sunday are doing an open discussion about racism in medicine. And I think it's fabulous to be able to have those discussions.
And those are great comments, Dr. Rockhurst-Graber. I would also say when you look at data regarding physicians of color, that there is an increased risk of burnout because of the constant daily microaggressions. I think when you then add that on to the issues that women physicians face, even pre-pandemic, that increases their risk for burnout. I would worry especially about women physicians of color and what they're facing pre-pandemic as well as during the pandemic. Unfortunately, most of the data out there isn't very good. As I mentioned, with the data looking at physicians who experienced the pandemic in New York City, they're looking overall at what's going on with physicians, but not disaggregating the data based on gender. That is a place where we need to start because we don't know we're making an impact unless we know what the prevalence of the problem is. But then taking it the next step to also disaggregate it by race as well as gender is the next step that we need to go to because we know there are risk factors there, but especially with the impact of the pandemic, we need much better data. And so if we know that there are going to be issues, and I think getting back to what I was discussing in terms of encouraging people to seek the mental health care that they need, I think it's especially in that community, but then you're also dealing with differences in what resources are available and what's the stigma and what's the culture and how ready are people to try to reach out and get the help they need and how supported are they in getting that help.
Dr. Templeton, I really appreciate your comments. As I'm listening to all this wonderful information, I see the organized medical staff at your institutions as being a tool that you can utilize to try to push some of this information out. Do any of the panelists have suggestions? So say I want to bring this up on my medical staff, where can I go to help my medical staff get some of this information out and actionable to the rest of my medical staff? Do you have some suggestions?
Well, if it's regarding issues such as state licensure changes, it's first of all, it's knowing what the language is in your state. And if you're if you are practicing in one of the majority of states that does not have language that necessarily is in line with what is recommended by the Federation of State Medical Boards, then that's certainly something where you can reach out to the project that I had mentioned through AMWA, where we're trying to collect that and so that people know what options are if they want to try to work with their state, but then also identify a champion, and we can help with that and give people a toolkit and show you how you reach out to your medical board to try to affect those changes.
Fantastic, thank you.
Yeah, Dr. Welsh, we do have time, I think, for one question before the top of the hour. And for the panelists, and the question is this: how are practices addressing the issue of accommodating not only women physicians, but women employees generally who were on maternity leave when COVID hit and wish to return to work?
Well, I know many large institutions have been hit fairly hard with the lack of patients, especially with elective procedures and things like that. I know our institution, we were able to not take a salary cut, but as of June 1, all productivity, you're back on a productivity basis, even though the productivity numbers are not there. So I think for women who have been on maternity leave, especially if they're in areas and where they're very procedurally based, they have a much harder time ramping back up again. So hopefully they are being made available for a lot of the telemedicine visits and the virtual visits, so they can ramp back up so that when they get back in to be able to do the procedures, that they'll be able to do that. And I think especially if they were off during the majority of this, they didn't get that education for the virtual visits that the rest of us got. But also to work with their own staff and their office to ramp things back up, because the numbers are still not there. We're not seeing the numbers of patients that we've had in the office.
Very good. Thank you, Dr. Kirschgraber. Anyone else?
So I'd just like to make a comment about the earlier question and the effects of persons of color. I just, during this time of COVID, we've also, in terms of, bias and those issues also, this is also the time of George Floyd, and looking at the effects of that incident and other incidents of a similar nature in our country. Yesterday was the 6-month anniversary of the murder of Breonna Taylor in Louisville, Kentucky. And we have not seen justice come about with that yet. And I think in terms of, what is seen for persons of color, in terms of women physicians in particular, we have to deal with that every day, seeing those incidents every day, and on top of the microaggressions that we have been seeing, and on top of that, we have to deal with COVID issues also. So I'd just like to add that additionally. Thank you.
And there's a new program about Vote ER that says we should be talking to our patients, every patient, about are you registered to vote? So I just got my packet, and last week I was registered 3 people while they were in my office. We don't tell them who to vote for, but we at least make sure that they're registered so that they can.
Very good.
That it was actually on one of our newscasts yesterday about literally registering patients in the emergency room using Vote ER.
Ladies and gentlemen, we are at the top of the hour. Okay, I appreciate certainly all of our speakers and all of our panelists.
I can't tell you how much I appreciate all of our conspirators, if you will. And we are there in OMSS to work with any and all folks. I think the key thing from tonight I liked was thrive, not just survive. And together we can improve these problems. OMSS is willing to continue this discussion and move things forward in a positive fashion. So thank you to all my colleagues in the Women's Physician Section, the Women's Medical Association. I see we have some folks from IMG and Minority Affairs on the call tonight. Together, we can make things better, and we can get through this and come out the other side better, stronger, and more together. Thank you for your time tonight. Let's keep the conversation going. Thank you very much.
Thank you very much.
Thank you.
Appreciate it.